And welcome to the podcast, Ryan. And definitely appreciate having you on. If anybody is following interoperability or health tech and doesn't know who Ryan Howell is, they're probably not very involved, right? I would say in all of the initiatives, especially over the last year. Let's take a step back, look at the full picture, and can discuss your work and federal policy, and then kill the clipboard.
Yeah, thanks, Gene. So I'm a principal at Levitt Partners. Levitt Partners is a unique organization. We focus on working at the intersection of federal policy and the private sector and finding ways where we could advance data exchange and interoperability and topics across both ONC and CMS. And so I joined Levitt Partners about 10 years ago. My background was really all in about trying to figure out ways to pitch products and figure out, who can buy our latest stuff, right? And so I relate to a lot of people out there around what this actually looks like for them. My goal now and our goal at Levitt Partners is actually to solve the problem and making sure that there is enough options out there for people to choose from so that they could be able to implement these things across the board and make sure that they're not, only have limited options for what they can do, and ensure that, the promise and the power of AI can be able to come to full fruition. So to your point, we started this process in the FHIR space a while ago, back in 2016, when FHIR was really just emerging as an actual standard. And there wasn't really anybody that was doing work outside of ballrooms on FHIR APIs, so to speak. I mean, I think Graham was kind of kicking things off. I think he started about 2010, 2012, that time frame, making that happen. But then when it hit the 21st Century Cures Act and then the ONC rule came out, that's when it started to become a thing. And at that same time, we started what was called the Karen Alliance. And so it's focused on getting consumers digital access to their healthcare data, where, when, and how they want to achieve their goals. And that was the first real multi-sector coalition around FHIR APIs in the entire country.
How did you get all the people that are on it into that group?
Yeah, so what Levitt Partners does, we do this for a living, is we form these multi-sector collaboratives that actually rally around some kind of federal policy. And we run about 30 of these a year, roughly. We've done work on drug supply chain issues. This work was specifically around data exchange and interoperability. And so what we did is we started with a group of convener. He was instrumental in helping to pull together a lot of different people around the table. David Brailer, who was one of the national coordinators for healthcare technology, in fact, the first one in the entire country. So it was very much a bipartisan coalition of conveners. And then if you talk about health tech ecosystem, there's more than 1,200 now. So they could bring all kinds of folks. And what we learned from this process, Gene, is we learned how to implement FHIR across the country. Apple joined the Karen Alliance with Ricky Bloomfield and his team. That changed everything. Now there's way more than 50 apps that have now connected that are consumer facing to this technology. There are more every day that are connecting. There's more than 150 organizations participating in the Access program that is related to consumer facing too. But the big thing we learned, Gene, is the fact that we really figured out kind of how FHIR can scale and what is needed and what isn't needed. And that has informed a lot of the other work we've done on the B2B side of FHIR too.
Yeah, and it's important to remind people that just a few years ago, FHIR was really on the back burner. And actually, I went through the same experience. Was working in a large health system and a large health insurance plan, UPMC health plan. And nobody even talked about FHIR, right? There was some like startup project in the back room, and that's kind of it. And obviously, then when the Cures Act took place, and that started to become front and center, where there's actually regulatory teeth. We actually recently had Don Rucker on the show, and we talked to him about some of the things about why is healthcare so different than other industries, right? And we see here, healthcare really, it does seem like we need this nudge, we need this push and nudge to get people to do what you would think would be common sense. But I think because those market dynamics are a little or a lot broken, right? I think we can all agree in healthcare. Why is that the case? And do you think where we are now is, the destination, or is it more of like the start of the journey towards where we all want to be? Obviously, we can talk about all the specifics of CMS health tech ecosystem, why that has been such a huge game changer in the past year and a half. And, you can definitely talk about that and kill the clipboard, I think, as examples of where government can participate the right way, right?
Yeah. So we have to kind of go through the quick history. The quick history is obviously High Tech Act. When that was passed, there was a whole bunch of money that was provided to providers to implement essentially a database of functionality, which is called the electronic medical record, which that digitized the data at least into a database itself. When I spoke to David Brailer at the time and David Blumenthal, both of them said one of our biggest regrets when we were national coordinator was the fact that we did not focus as much on interoperability as we should have. The fact that trying to get the data to move from one system to another. Now, there were private sector initiatives that happened. There was something called AHIC, the American Health Information Consortium, I think is what that Governor Levitt actually started in 2005. It started talking about standards, and he and I joke about that a lot. He was just too early. It was it was actually before high tech, and I said that you had the right idea. You were just way too early on this stuff, and here we are in 2026, and we're still unfortunately too early. We're not implementing FHIR everywhere yet. We're not even close. So it's like, how do we advance this faster? And we have to start talking about it not as a technology problem, but as a business problem. And if we can start to kind of reframe it and stop using all these kind of technological acronyms, we'll have a lot better opportunity to be able to get the message out as to why moving to modern systems are important and modern data exchange frameworks are important. That's what my hope is. The groups that you and I hang out with, Gene, we talk about acronyms all day long, which is great from a tech perspective, but it doesn't move the needle for business folks that have 1,000 things to do and don't understand why these things matter. So I think that's important. And then, so to your answer about kind of where we are today, we have these EMRs and they are exchanging data, certainly on the national networks and other places today, but it's mainly just EMR related data and clinical data that's between the EMRs themselves. There's some public health data being sent, but that's not necessarily as much on the national networks as we'd like. And the only thing that's really being transacted in FHIR today is individual access. And that's largely because we don't need the national networks to do that. Apps can be able to connect to an API endpoint anywhere in the country, payer and provider endpoint, and they can get access to the data. It's hard, but it can be done. And a lot of them are using the national networks to expand their scope, which is great. But we have this problem where we've got portals everywhere. And it's very difficult to try to actually aggregate the data for an individual if, in fact, you have way too many ways to log in. So that's where digital identity comes in place. We started talking about digital identity in 2017. I think we were the earliest organization in the country to start talking about it. And when we started talking about it, digital identity means, can I prove that I am who I say I am using the technology such as Clear and ID.me and login.gov. And that has now become industry standard. It's now Medicare.gov has implemented it. The health tech ecosystem has required it. TEFCA has now required it. And we have a really unique opportunity now to say, wow, we can actually say, we can have like a single sign-on for consumers to access their data. And we can have a single sign-on for businesses to potentially access the data if, in fact, they're authorized to receive it. So that's another kind of spicy topic. We want to get into that about why I think digital identity is needed also on the B2B side as well as the B2C side. But we can go wherever you'd like.
Yeah, absolutely. We should start with the kill the clipboard because it is an important part of kill the clipboard. Because kill the clipboard, even though it focuses on the clipboard, it's actually not about the clipboard. It's about you as a patient being in charge of your health data, right? And so, but we can't do that until the system recognizes who you are and lets you access all of your data, and then prove your identity essentially. So kill the clipboard, like that was in February 2025. You, I think, offered that white paper, and then it became a national health initiative. How did that happen? That must be an amazing, remarkable coincidence.
Yeah, it was. So regardless of who is in the White House, Gene, one of the things that I've realized, especially over the last decade, is that there are good ideas out there that are very much nonpartisan. And so what we wanted to do is we started this conversation on Kill the Clipboard back in like October before the election was finalized in November. And so we really didn't care at that point in time who won. We wanted to start a conversation with the new administration on what needs to happen in order to get the data to move. And so we wrote that paper. We released it in February, as you mentioned, of last year. And the administration decided that there was some good ideas in there, and they decided that they wanted to actually continue to move forward and figure out how to advance fire. It was largely due to Amy Gleason's leadership and obviously leadership of Dr. Oz and others, which is great. We were just really super excited that the administration wanted to pick this up. I want to be clear about a few things, Gene, in the paper, and folks can Google "Kill the Clipboard" for Levitt Partners, and they'll see the administration's initiative, and then they'll see our white paper. Our white paper had a lot of things in it, including how to advance fire APIs for digital quality measures, how to improve TEFCA, a whole bunch of other things. Biggest idea that it had, Gene, at the time was that we needed to actually redesign the Cert program, the ONC Cert program. And what we said is we've done a really tremendous disservice to the American consumer and to the American healthcare industry, because through regulations, what we've done is we've left in place the Cert program for too long. So I'm going to oversimplify this, Gene, but the Cert program requires that health systems buy an EMR vendor of which the federal government tells them how to build it. There's a whole bunch of requirements for how to build one of these EMRs. And the federal government makes these requirements, and every year or 2 years, or depending on their functionality, they continue to provide more description as to how the government is to build these systems inside the system. So it's like going to a private sector enterprise and saying, we're going to tell you how to build your system. And the EHR vendor has to juggle the requirements that come down from the federal government, the innovation that they want to develop themselves, and their client requests that they have too. So they've got three things they're trying to juggle in their product roadmap, which slows down innovation at the EMR level, which is really problematic. And it gets a lot of their clients angry because they like, why can't you move faster on some of the things we talked about? And it stifles innovation outside the EMR too, because there are organizations that can't necessarily provide innovative products for providers who are doing things beyond fee for service. So an example of that is if I'm a value-based care company and I'm doing a whole value-based care platform and company, and so I have a totally different reimbursement mechanism, I have a totally different workflow, I have a totally different set of innovative care plans and guidance that I'm doing with social determinants or ride benefits or all kinds of other things that I'm doing with whole person care and wearables and all kinds of things. I am very restricted because I now, if I got to build Medicare or Medicaid, I've got to have an EMR and I potentially have to have a value-based care platform or value-based care like EMR. And I've got to have both of them because that's what they've told me to do. I've talked to many value-based care organizations and they're struggling because they need to have both and they don't have the funding to have both. And so what we have is a situation where we need to eliminate trying to find ways to certify the EMR and inside the EMR itself. So what we need to do is really, and ONC has done this. They released HTI-5 back in December. They've eliminated about more than half of the Cert requirements, which is great. We're hopeful, and it said in their rule that it sounds like they're going to move in this direction, that they can do essentially what the ideas we had in some of that paper, which was, could you actually certify interfaces and not the functionality? That was really the big idea we had in the Kill the Clipboard paper. If we could certify interfaces and make sure that the interfaces, were up to internet standards, that changes the game completely, Gene, because then you have a situation where people can then choose, what they want to use for Cert. That could be all kinds of things. It could be their EMR, it could be their HIE, it could be a private sector vendor, it could be a cloud provider, it could be all kinds of different entities that they could be able to use that relates to this certifying the interfaces functionality. And it helps to be able to improve performance across the board and improve the infrastructure needed to actually scale AI, which we don't necessarily have today. So that is really the big idea that came out of that Kill the Clipboard paper, along with obviously all the ideas that we started with the Karen Alliance, which is around digital identity, whether it's a National Provider Directory, which was obviously part of 21st Century Cures, or any of the other kind of really innovative things that are happening right now in the health tech ecosystem, which is really exciting stuff.
Great. That's, I think, an amazing contribution. And the point to our listeners is that this is entirely bipartisan effort that has went through multiple administrations, all the way if you go back 10 years. And it's kind of like we're holding the torch and there's runners just passing the torch, but people are trying to get to the finish line at some point, right? Okay, so we're here now. We got HDI 5, and I think I hear HDI 6 is on the horizon. I think one of the things that's missing, and you correct me if I'm wrong, is like actual performance requirements for some of these APIs that even though you may be a EMR vendor and you have, a certified EMR, and you're, conforming to the G10 requirements, they don't have to be performant because there's really no performance, requirements because it could be, 30-second latency or it could be sub 5 second. Are we going to see some of that in maybe the HTI 6? And then the bulk, obviously, the big one in the room is like the bulk fire, which I think a lot of people want, but not sure how to make it work. Maybe that's something else you could touch on if that's what you think will happen at some point.
Well, I think that in HTI 5, ONC did indicate that they want to move beyond a read only requirements, right? So to me, what that means is they may want to move to read write requirements. And the question is, can you read write into the MR? Can you read write into the cloud? Can you read write? Where does that actually live? It'd be interesting to see kind of how that unfolds. They also kind of made mention of this performance of APIs too. And so what folks will generally tell you is that, let's take just the ecosystem as it exists today, Gene. One of the challenges we have is because many of these EMRs are on-prem or not necessarily, their data models are not cloud-based, or they're, smaller FQHCs or others that just have very limited and older EMRs that just aren't very performant. It's hard to scale nationwide interoperability in that model if, in fact, it's not in the cloud because you don't have unlimited compute. And so you have a situation where you can't, to your point, really get to bulk APIs. You can't really get to a point of even nationwide interoperability. If one of the things that some people don't like when I say is that if TEFCA worked perfectly and every payer and provider in the country were connected to it in a Fire API format, and we started pulling on data, and even if it was record location services, right? And all our RLS worked absolutely perfectly. Almost not the entire system, but much of the system would actually go down. It would go down because it's not designed to actually have that many pulls and pings on it and pulling the data and doing all of that stuff. And so I'm worried that we're a little bit on a bridge to nowhere. And so I think what we're trying to figure out is what's the right answer for the country. And we think based on us, and it's not just us, I want to be clear, Levitt Partners, we talk to tons of dozens and dozens of organizations, payers and providers and vendors and others. So our opinions are really informed by them, consensus opinions of what needs to happen. And, what people tell us repeatedly is that especially on the provider side, they're like, we would love to be able to have a cloud-based platform and get all this information out of our EHR and use it for purposes that are non-EHR specific, right? Whether it's quality measurement, other things that they're actually doing. That's kind of, a lot of them are telling us that. Payer side, they've built a Fire ecosystem, right? Because they had to do it for individual access. And so as a result, they've got a whole Fire ecosystem ready to go, and they'll send APIs back and forth today. They spent hundreds and hundreds of millions of dollars setting that up. And how do we actually get that performant across the board? Accessing an API is a lot easier than how they do it today. And it's a lot less expensive too. So how do we figure out a way to scale that? And I think they're ready. I think mostly if, providing generalities, most of the major national payers are ready from a Fire API perspective to do B2B and B2C. The states are a little farther behind. Probably about half of them are ready. The other half aren't quite ready yet. And the payers want to be ready, especially the major ones, the major national ones, but they have been confined to this idea that, it's been a struggle to try to get some of their data into the cloud so that they could be able to send this back and forth to the payers or to others that are for, again, non-EHR reasons. A lot of them have EHRs that do wonderful things for them and do maybe everything that they need them to do, but a lot of them don't. And a lot of them want to be able to have that flexibility.
Yeah, and people I think don't understand that there's this whole ecosystem of everything from quality reporting and analytics to population health to a regulatory requirement to revenue cycle, which I know you're a big fan of. All of this sits on top of the EHR. It's not a module within the EHR. So like we've enabled that API layer for getting all of the patient data, but it's not for the population. So that when we're talking about, hey, the payer actually needs an extract of 100,000 patients. How do you enable that without these custom, agreements and custom work that has to happen between payers and providers, and why that's all that added cost that then is passed down to us as consumers. And I think that's the layer that I would say most people are not thinking when they're talking about Fire, and it is always like hard to explain to people, well, what is an analytics use case for fire? Well, that's a whole different ballgame. And you probably are familiar with the SQL on Fire effort and folks that have been working on that. But ultimately, you should be able to use, REST APIs, and you should be able to use them for many different use cases, not just
Yeah.
individual access. So yeah, what? Okay, so yeah, we can kind of talk about quality, and I have my thoughts on that as well. But like, we have this transition to digital quality measurement, obviously, and then we have this transition to value-based care that we're all in different stages of across the country. So how do you marry those two together? You think we need one to trigger the other, and then do you think that fire is also the answer to making quality measurement scale and
Yeah.
remove this
So
giant overhead?
Yeah, so let's talk about that. So about 3.5, 4 years ago, we had some friends at NCQA and we had dinner with them. And I said, why is it so hard? Why can't we? They knew Fire APIs. A bunch of the friends there knew Fire APIs. I said, why can't we report digital quality using or quality measurement using Fire APIs? What's the problem? And so it started a conversation, Gene, about what is involved in it and the fact that they wanted to solve that problem. And they said the one thing that they told us was one of the biggest problems was that there was this thing that Bryn Rhodes was creating called the Clinical Quality Language, CQL and HL7, and it really wasn't kind of prime time yet. And Bryn had been doing a lot of great work in HL7 to try to actually upgrade it and try to make sure that it's good. But he was in ballrooms around the country and like doing the best he could with the engineers that came to the HL7 Connectathons, which, as you know, is like not even like a hair on the back of a wart of a hog. That's, like the amount of people that come to those Connectathons versus the amount of people that are in healthcare data technology. It's just, there's an order of magnitudes difference.
I mean, all the power to them though, because those people have been doing that for so long. I'm like, it's almost like a family reunion for a lot, but it's
Well,
a very small portion of the actual
it's
community.
true. It's true. So we went to Bryn and we said, hey, Bryn, would it be helpful if we could kind of shine a light on this and get a lot more people to the table to try to improve it? Would that be helpful to you? And he said, yeah, it would absolutely be helpful. And he's been a super great participant in all of this. And so we convened a group and we called it the Digital Quality Implementers Community. And over the last 3 years, we've made well more than 250 changes to CQL. And a lot of those changes, I don't want to give the exact numbers, but like a ton of those actually, all 250 actually came from really the CQL kind of community, not just the ones that obviously Bryn's doing with an HL7, but also the ones with Digital Quality Implementers Community. We also got people that were actually standing up CQL engines and said, what challenges are you having right now? Firely and Smile and all the other ones that are out there to make that happen. What does that look like? And then we got NCQA to the table and we said, what are you experiencing? What are you seeing? How do we figure out a way to actually kind of certify these engines to make sure CQL runs with NCQA? And NCQA is something called Digital Content Services, which is their version of Digital HEDIS. And we got them all in a room. And Gene, honestly, I don't know if that if we could, we would have gotten this far without that work. I know there's work going on with SQL as well on Fire, because that's obviously a much bigger community to make that happen. It's still pretty nascent from my understanding. And obviously NCQA doesn't have their measures exactly aligned to SQL. That's going to happen over time. And then the folks that are on the business side that have wanted to do quality measurement for a long time and actually analyze the quality measurement and understand the gaps in care and engage in some of this stuff, they're not figuring out ways to just get the data from point A to point B or try to do it in a format compliant to HEDIS. They're actually figuring out a way to close the gaps and improve quality at the point of care. And I think that's the reason everybody got into quality in the first place. These kind of, ideas of the fact that we're just, manually doing this doesn't make much sense. And then I'll end with this, Gene. There's also this thing on the provider side where providers, if they're part of the MSSP program, have to report on quality measures as well. Well, CMS has these antiquated things called QRDAs and all kinds of stuff that doesn't make much sense. Like they're not related to Fire APIs at all. And they're very manual. They're very labor intensive. They cost a lot of money. And so an ACO that's trying to save money, it doesn't make any sense. So why can't you just send the Fire API to CMS? Well, like, why can't we just send the Fire APIs? And there's innovative providers now, ACOs, that are doing that. Michael at Providence and Anna at Multicare and all kinds of folks out there that can be a thing. Now, CMS needs to revise some of the regulations around this, and they've publicly said already they're not going to issue any additional quality measures that can't be reported using USCDI and Fire. So there's some gaps we still need to close here on the regulatory front and other areas, but the end result, Gene, is to reuse functionality. Right? Providers should send Fire APIs USCDI to payers. Payers need to send the Fire APIs to HEDIS, and providers need to send the same Fire APIs to CMS. Like that is just needs to be level setting. Like, why are we doing it differently? What needs to change to make sure that we can do that going forward? That's the thing that's transformative for healthcare, and that's the reusability of that. We can't necessarily do that with X12 today. We can't do that with some of the CCDA stuff. We can't do that with anything else we have. Why can't we do that now with Fire? And it's not just, by the way, quality. We've been done work in public health. Why can't we send the same things to our public health authorities, right? Why can't we send the same things to all of the different places we need to send data? That's the work that we're doing every day, Gene, is to figure out ways, what are the things that need to change in policy? What are the things that need to change in the standards community to make that happen at scale?
Yeah, no, absolutely. Yeah, I had a chance to contribute to the CQL definitely community. I've done work with that, and I'll be a little bit of a contrarian here just because it's more fun to disagree. But like, I do think that CQL and SQL is going to be the game changer in terms of the adoption, just because in my experience and having heard all the feedback from, a lot of people in the industry really struggling to implement CQL at scale, I think. And, CQL is great as its own language and can be used to define these measures and how they should be executed on top of Fire. But the execution layer itself, I think if we can make sure that runs on SQL, which every health plan in the country and provider system has very talented SQL developers that they've probably had on payroll for many, many years, and they know exactly how to tune SQL queries and all kinds of things. So actually, Evan Masichek, I think you know from NCQA, did a great presentation at Dev Days about he figured out the perfect 100% CQL to SQL conversion. So looking forward to seeing that. Hopefully Optum is not going to trademark that, but we're going to collaborate on an implementation guide. And then also enable some of this maybe open sharing of CQL measures as well, because it's not just has to be HEDIS. HEDIS obviously is a proprietary set of measures, but there's many other measures like the CMS measures you mentioned. And I think having a community out there with people with, that you can go and you don't have to pay some vendor millions of dollars for developing these measures, which, by the way, they do. They charge over $150,000 to develop a custom state measure. At least that's when I was at the health plan. Anyway, I'm sure you know all of that, and that's why we're trying to move away from that. So, okay, going to some of the big
Gene,
things that
Gene, let me
please
react to your comment.
Go ahead.
Well, I don't think any of us are married to CQL per se. I think the challenge is that the Fire community hasn't figured out a way to truly do Fire and SQL today, right? Glad to hear it. We worked with Evan when he was at NCQA as well. It's still immensely complicated, and it's also immensely complicated because NCQA has got to figure out a way in which they can be able to support that using their digital content services. So I would just tell you, and this is not, again, this may be contrarian perspective as well. We are 3.5, 4 years into Fire and CQL to just get that to work. My only point is that that's not the core problem. The core problem is the fact that we have quality measurement agencies or departments, I should say, inside of health plans that are paranoid by the fact they're going to lose their job because this can all be done digitally. So we need to help them understand that actually the purpose of this, again, every health plan is going to make different decisions on that. Maybe some of them let all of them go. I don't know. But the whole purpose of quality measurement reporting is actually to not just do the reporting, but to do the analysis on what actually is happening and what can be changed, and making that case to the individual departments within a health plan that have typically done this quality measurement stuff manually for years is going to be the biggest barrier to adoption across the board. It's never a technology problem.
Absolutely. Like all of this, right? We've had a lot of the technology for this for years now. What is the date? Do you have any updates maybe that we should think about? I remember both in CQA and CMS talked about 2030, especially when you're talking about the QRDAs and, MSSP and the CQM conversion. I think these EMR vendors, they're sitting on their hands. They're saying, well, why should we invest into this? Because we don't even have there's not even a date. And we're saying, well, you better start now because guess what? it's probably going to be within the next year or two that you're going to see regulation come out. Am I right on that?
I don't know when the regulation is going to come out. All I know is what CMS has said publicly, and they have publicly said that they're committed to FHIR APIs for providers for sure. And they have said repeatedly in multiple rules that they've asked for feedback on FHIR APIs and what specific measures need to be changed as it relates to FHIR APIs and all of that. So it is certainly a priority for them based on what they've said in rulemaking and what they've said publicly. So when that happens on the provider side, I don't know. NCQA has been more direct and more public with it. I think the perspective that I take, Gene, on this is in decades, because that's how federal policy works. EHR took at least a decade to do, right? From high tech to actual 95% adoption. FHIR's taken more than a decade. We're 16 years in and we're still not where we need to be. Right. And this is another issue that's going to probably take at least another decade to do. And nobody likes when I say that, but it's true, especially the vendors don't like when I say that because it doesn't help them with their go-to-market strategy. But it's true because it takes that long for the policy, the standards, and the technology to all align. If we can get them all to align, and then it becomes a matter of making that happen. And we think, back to my point earlier, Gene, certifying these APIs rather than certifying the functionality inside an EHR will help that innovation to actually move faster. That's what we think the next decade is going to be, is once you certify the APIs, providers will have choice, and APIs will be hopefully much more performant than they are today. And when that happens, then you can start to move into an area where you can get into the fun stuff that we've been doing in connectathons forever, like bulk FHIR. And then we can start running AI against it too, because then we can be able to have structured data that helps better inform the models. And it just gets to a better point than where we are right now.
Yeah, and to be a little bit more optimistic than pessimistic here, I've seen a big sea change in terms of just fire literacy and being able to, have more people that actually understand what an implementation guide is. What is the difference between, CMS 0057 and, payer-to-payer, provider, patient access, especially like the health plans and and a lot of the providers. And I think AI has a big, something to do with that, because right now you can basically stand up, a lot of these solutions very quickly, right? We haven't seen that before, where you have maybe a few developers that are maybe familiar with it. Maybe one of them has been to a connectathon, and that's pretty much it, right? And that's why I think you're also seeing a lot of barriers to something like a CQL engine. And as much as people would love to, just go to a vendor and have it be deployed, the reality is, I think, in my opinion, the reality is a little different, because it does require so much plumbing, and there's so many different things like mapping data and custom, solutions that you have to kind of, based on the organization itself, have to, develop as well. But just like any other ecosystem, it has to develop naturally, and there has to be vendors that support all these different tools and people that have the, the learnings from doing it over and over and over and failing right at it, which we've done for years. So anyway, let's go to another topic that I would love to ask you about, in terms of just your honest scorecard, facts just being 10, 20 years ago, being just nothing but faxes and paper clipboards, to now where we have the patient APIs, we have 150 different people participating in the access program potentially. What's the next thing? What is the next big thing that, we're hopefully are going to see happen just across the industry? Just, we're seeing the CMS health tech ecosystem. We're seeing all these things kind of come together. What is the next thing that you're looking forward to from your perspective, being able to kind of see the whole landscape?
So we didn't talk a lot about the CMS health tech ecosystem. So there may be folks in your audience that don't understand what that is. I hope there isn't, but there may be. When that was announced last summer, it was announced, and then nothing else was really publicly said for many months. And people may have thought, what's going on? Nothing's happening. What does that look like? And then there was some public announcements that happened kind of late last year, and then end of first quarter this year. We expect more things to happen in the future. And as a result of that, there's going to be an opportunity. So the question is, what's happening? And what's happening is there's a Slack channel that has more than 1,200 organizations part of it, 12 different work groups who are implementing FHIR APIs. That is their primary focus. We're not focused on CCDs. We're not focused on NCPDP. We're not focused on HL7V2. we're not focused on any other technology but just the FHIR APIs for both B2B transactions, because now they have an e-prior authorization work group with multiple payers and providers that are participating in that, and for B2C transactions for Kill the Clipboard for individual consumer access as well. The reason that's so important is ONC released a blog post that basically said, we as TEFCA, meaning ONC, is like the tide, slow moving back and forth. It goes back, been doing it for 10 years. We're trying to get consensus. It's a network of networks type model versus what's happening in CMS health tech ecosystem, which is go, go, go. Let's test it out. Let's see if it works. Let's draft up a spec. It's basically like the largest connectathon we've ever had in the entire country, Gene, is what it is. And we're figuring
Yeah.
out if it works, right? We're figuring out, does the spec work? How do we actually revise it and improve it? It's fully open. It's fully transparent. People are raising their hands, volunteering to do stuff. It's not part of any regulation. The federal government's there. The private sector is there. To me, honestly, it's the most innovative thing I've ever seen, Gene, because what has historically happened in federal policy is that the feds have gotten input, potentially, not formally, but from people that just randomly kind of show up on their doorstep and give them advice or things they want to do. They come out with a federal policy, and then there's this formal comment period that goes on, and then they try to rewrite the policy based on the comments that come in and hopefully get it right, right? That includes standards and all the other things that are related to it. That is hard because it's hard to get federal policy right. And so what is valuable about what's happening here is the private sector is trying to get it right. And when they get it right, the hope is that can scale. I mean, hopefully ONC can point to that and say, hey, this worked in health tech ecosystem. Let's point to it into part of the FHIR API stuff that we're actually doing too. So I think that the most exciting thing over the next few years is going to be what comes out of health tech ecosystem, because I believe it's going to be the foundation for how FHIR API transactions, digital identity, and everything else that we need to do to modernize our data exchange will be informed. And it's going to be the foundation for how that actually happens. Now, CMS has been very clear they're not going to put it into regulation, but that doesn't mean other administrations or other agencies potentially could put it into regulation. And it also doesn't mean that the private sector can't just adopt it. Right? If it works and it's good and it's operating and it's better than what they have today, we anticipate mass adoption from this because we think that there's opportunities for organizations to do it better than they do it today.
Yeah, absolutely. I'll just say like I'll hop on once in a while to some of those calls, and I've been involved on the provider directory one that I think is just an awesome thing to see, because like over years and years you have every company in healthcare basically replicating their own provider directory, and just to see, oh, wait a second, we actually have every health plan, or at least the most major ones, on a call with somebody that's trying to fix how this is all working, which is insane, right? And so that's very promising. And even some of the like the patient app ones, and there's just so many of these different work groups, and it is very organic. Like it's not all like, well, yeah, CMS says this, and it is actually companies sharing their experience, which is a pretty incredible, because generally what you see is companies go in and build stuff and then they release it, and that's how the market, and then they might share it as a open source project or a white paper or something. This way, they're actually building the spec together, and then it's more than one company, right? And so that is very nice to see. And I've even talked to some like founders that are just one person founders, that are people that just have a good idea and they have a full-time job, and this is their second job. They have this idea and they're going to go vibe code it and get access to the networks, get sign off, get certified, and boom, they're on the list with some of the big names, which is pretty cool. To do that. That's what I feel like America's really like. That's what America's all about. The small guy being able to start things in your garage, and you never know where that could happen. I would say yeah.
The dynamics on those calls are incredible, Gene, because you have billion-dollar companies and startups talking to each other about how they can connect and finding ways to be able to do that. And it's an idea meritocracy. Like the best ideas kind of win out, right? In terms of where this looks like. And to your point, the safety, security, and technology associated with how this is being designed far exceeds anything we have today on just the current way that we exchange data using CCDs today and the current infrastructure we have. It far exceeds what we actually do with regards to X12 and some of the other HIPAA-related transactions. It is more secure, more privacy preserving, and more consent-based and more consumer-centric than anything else we do. And to your point, I think it is so incredible to see these companies that they get certified, these consumer facing app companies, they get certified, they do the Karen Code of Conduct, they make sure they're compliant with that through Direct Trust or Dime or others that are out there. And then they get listed in the Medicare app library. And then these patients can be able to choose these apps that they know are actually making sure that that data is more privacy preserving and more secure than really almost anything we have today in HIPAA related data exchange. That's what's exciting, is that we've always looked at it in the Karen Alliance as HIPAA being the floor, not the ceiling. And so this provides us an opportunity to be able to test that out and figure out a way to scale it. And then we can scale it using TEFCA. And remember, CMS aligned networks is a specific approach for how Firebase data exchange should be handled on a network. And TEFCA is a network of networks approach. There's two very different purposes for why those two entities actually exist, and those two, policymaking approaches too. So kind of this conversation around, TEFCA is better than CMS aligned networks or whatever, or vice versa, shouldn't be the case. We actually need both to scale.
Yeah, and I have to explain this to people. It's like you can't just have one data provider also, because there's not one network that has everything out there, and TEFCA doesn't have everything, and a lot of providers are not on TEFCA. And so you really do need a collection. So it's almost like connect to the, ones that are relevant to your population, to your patients. And yeah, so in terms of since the CMS and health tech ecosystem got announced, that was a year ago, what would you point, like, is the Medicare app library, would you say, is like one of the big things that now exists that didn't exist before? Or would you say, is it CMS aligned networks? What would you point as like the big
Well, there's
thing?
been a number of major accomplishments. I think number one is National Provider Directory that you mentioned before. The National Provider Directory, just so folks understand, one of the reasons we have such a poor situation that we're in right now is we never identified that the provider is who they say they are. There was no real identity proofing process digitally for the provider to do that. That changes because CMS has now adopted digital identity technologies. And as a result of that, they are now identity proofing individual providers. That's important for a ton of reasons. And once they've identified an individual provider, they can link it to that individual provider's FHIR endpoint. That's their digital address book. That's how they find them out there. When those two things happen, then you can wrap everything else around it. What billing group they're part of, what physician group they're part of, what health system they're part of, the hours, locations, all the other things are metadata that actually wraps around those two fundamental principles. That's what CMS is doing, and that's the mode that they're going into. That's why I think this time is going to be much different than we've had before, and why a lot more optimistic than other scenarios. So that's, I think, deliverable number one. Deliverable number two is we actually have a patient matching approach, a national patient matching approach for the whole country. It's dozens of pages long, but it is out there. It's been tested and used by a number of different entities. It's being tested and used by others as we speak. It's being refined. What does that start to look like? If we had an approach for how we do identifying information, that patient matching, that could be really interesting. But we think actually primarily if people just adopt digital identity, and I know Don mentioned this on your podcast too, people implement digital identity and that becomes the foundation. Patient matching over time goes away as a problem. That's the hope, right?
Right.
And that's the anticipation to make that happen. So we'll see kind of where that goes. We're not there yet. The other major deliverable is that there is a whole set of MVP requirements for Firebase data exchange that includes all kinds of topics, whether it's digital identity, whether it's patient matching, whether it's all the stuff related to audit trails. There's a whole bunch of things that are wrapped up into that MVP document. And there are literally dozens and dozens of companies that have said, we're going to go first. We're going to go early and often, and we're going to test this out and we're going to adopt it, whether it's QHINs, whether it's EHRs, whether it's payers, technology companies, all kinds of states are involved in this effort too. All kinds of organizations are saying, we'd love to participate in it. So you're going to see more of that going forward. And then the hope is that we'll see it scale around the country over the next few months and years.
Yeah. And what would you recommend to like states in particular, I know there's a lot of rural health initiatives going out right now across the country. And now that all the states have this kind of money on the table, right? And a lot of the problems with rural healthcare is lack of interoperability. So what do you think, what's the biggest piece of advice for the states when they're starting to think about how to spend that money and how to best align those
Yeah,
resources.
rural health transformation actually provides a real opportunity to truly transform rural health, which means how do we get rural health from a technology perspective? How do we get rural health connected to the rest of the country? Right? What does that start to look like? And give you the story of Africa. Africa basically said, they when they started in terms of modernizing their kind of infrastructure from a technology perspective, that was well beyond kind of the PC age, right? They kind of did that and they jumped right to mobile.
Hmm.
And so they just skipped over all that we did in the Mac days and all the other stuff in the 80s and 90s, right? They jumped over that and they went right to mobile. This is an opportunity for rural health to go right to the cloud and AI, and which includes APIs too, right? And so we think that there's opportunities to do that. And we think the thing that scales is open standards. We've done an open standard for data normalization with the PICI Alliance, PIQI, if folks want to be able to look more about piciframework.org, which is a data normalization layer for the whole country that's open standard. We think there's open standard data logic models as well. We're working with Graphite Health and others to make that happen. We think there's open standards, obviously, with Fire APIs. The amount of open standards out there are pretty significant. And so if rural health can start to adopt those and they can be able to aggregate that data into the cloud, there's really innovative stuff happening in Utah, as you mentioned, with our One Utah initiative that we've been working on for many years, where we've got to get payers and providers in a room to talk about things other than financial stuff. We've got to actually get them talking about how do we make each other's lives better? And most importantly, how do we make the consumer's life better? How do we make the patient, the member's life better? What does that start to look like? How do we eliminate all this back and forth that we've had to have this middleware to try to figure this out because we haven't been able to talk to each other? What if we started to talk to each other? What does that start to look like? And how do we start to make each other's lives a little easier? And in exchange, and this is the most important thing, how do we make the person's life easier? Because it's a miserable situation out there, as you know, Gene, it's the byproduct of a lot of different antiquated and competing business models that have prevented us from really just doing the right thing. And it's time to do the right thing.
Yeah, absolutely. Maybe we should just buy everybody a phone and Claude and just honestly give that to people, and that would be like probably a huge help, and make sure that they can connect to their health data. Yeah, so fascinating, and thank you for making the time. And I know I had to pull you away from your family and your spending time with your children. I'm sure as my children are coming back from sleepaway camp, so my honeymoon vacation is over here pretty soon. So thank you, Ryan. Appreciate your time and definitely coming on. And maybe we'll have you again in sometime to talk about all the other exciting things that are going to be happening by the end of the year.
Awesome. Thanks, Gene. Appreciate it.
Thank you, Ryan.